Macrophage activation syndrome, MAS, is a severe, potentially life-threatening complication that can occur in patients with various rheumatic diseases, most commonly systemic juvenile idiopathic arthritis, SJIA, and systemic lupus erythematosus, SLE. MS is characterized by excessive activation and proliferation of T lymphocytes and macrophages, leading to hypercytokinemia and hemophagocytosis. Classification criteria for MAS in the context of SJIA. In 2016, Ravelli et al. Proposed classification criteria for MAS in the context of systemic juvenile idiopathic arthritis. These criteria are widely used to identify a MAS in clinical practice. Required criterion: ferritin 684 nanograms per millia plus any two of the following five clinical laboratory criteria. Hash clinical and laboratory criteria. 1. Platelet count 181,000 macrocytes. Thrombocytopenia is common in MAS due to bone marrow suppression and increased consumption of platelets. 2. Aspartate aminotransferase AST 48 ULI. Elevated AST indicates liver involvement and tissue damage, which is frequently seen in MAS. 3. Triglycerides 156 milligrams per deciliter. Hypertriglyceridemia occurs due to altered lipid metabolism, which is a common feature in MAS and other hemophagocytic syndromes. 4. Fibrinogen 360 milligrams per deciliter. Hypofibrinogenemia reflects consumption coagulopathy, a hallmark of MAS. 5. Hemoglobin 9.0 grams per deli. Anemia is common in MS due to hemophagocytosis and bone marrow suppression. Additional considerations. While the above criteria are specific to MAS and JIA, MAS can also occur in other rheumatic diseases, particularly SLE. The diagnostic approach in non-SJIA MAS often involves clinical judgment and may include additional laboratory findings such as hyperferritinemia, ferritin levels often much higher, sometimes 10,000 nanograms per milliliter, cytopenias affecting more than one cell line, elevated soluble IL-2 receptor, SCD25, this can be a marker of T-cell activation, elevated D-dimer reflects coagulopathy, elevated lactate dehydrogenase, LDH, indicates tissue damage and hemophagocytic activity. Other MAS features. Fever, persistent high fever unresponsive to antipyretics is common. Organomegaly, hepatosplenomegaly may occur due to the infiltration of activated macrophages. Neurological symptoms, altered mental status, seizures, or other central nervous system involvement may be present in severe cases. Differentiating from other conditions, MAS can be challenging to differentiate from systemic infections, sepsis, or other causes of cytokine storm. The rapid identification and treatment of MS are crucial, often requiring high-dose corticosteroids, immunosuppressive agents, and sometimes biologic therapies like IL-1 or IL-6 inhibitors. Understanding and applying these criteria can aid in the timely diagnosis and treatment of MAS, improving outcomes for patients with this critical condition.